Good evening, everyone. We thank you so much for logging in, and we welcome you to this grand finale of our 3-day depression series. My name is Dr. Muyanga Mark, and I am your moderator for this evening. So the topic of discussion this evening is the treatment principles of depression, and this is going to be ably done by Dr. Sadat Katama. And following the presentation by Dr. Katama, we are going to have a question and answer session, during which session we are also going to actually display or have an important poll. So we are kindly requesting that you share your views in that poll to help us to improve our sessions in the coming weeks. That's because we have shared earlier that we are going to be having sessions for the next 6 weeks every day from 7 p.m., not every day, rather on Tuesdays, Wednesdays, and Thursdays from 7 p.m. to 8 p.m. So before we dive into today's discussion, allow me to give us a quick recap of the past 2 days or the past 2 sessions. So on Tuesday, Dr. Katama helped us to lay a solid foundation by unpacking what depression really is. And he started by taking us from the days of Hippocrates, who described melancholia as fear or sadness that lasts too long. And then he proceeded to the modern DSM-5 TR and the ICD-11, which now defines major depressive disorder as a medical illness, which is marked by changes not only in mood, but also in thinking, in sleep, in appetite, energy, and daily functioning. We also learned that for a diagnosis of depression to be made, a person needs at least 5 symptoms lasting 2 weeks or more, and one of these symptoms should be either a persistently low mood or a loss of interest in previously pleasurable activities. But Dr. Katama didn't stop at the textbook. He also reminded us that behind every single depressive symptom that you see, a person is also struggling to function at work, at school, within family, or within his or her social spheres. He also took us through the diagnostic tools such as the MINI, the SKID, the PHQ-9, which help clinicians to actually assess systematically rather than relying on a gut feeling that this person looks sad, so probably he could be having depression. Let us start on 20 milligrams of fluoxetine. He informed us that we have tools that can enable us to make informed clinical decisions. We also explored with him how depression often follows a recurrent and relapsing course. And the meaning we got from this is that it actually requires follow-up and not just first-line treatment. So one key takeaway from day one was that partial recovery in the context of depression is not enough. Our goal, and he's going to further emphasize this during the course of his submission, is full remission or disappearance or full remission or disappearing of the symptomatology. And this is because lingering symptoms or residual symptoms of depression are actually predictors of relapse. So in short, Tuesday grounded us in what depression is, how we diagnose it, and why early complete treatment also matters. So fast forward to yesterday. Yesterday's session took us straight to the engine room of depression, if I may say that. So we came to learn what actually happens in the brain and the body. Dr. Katama started by reminding us that depression does not come from one source. It is multifactorial. That is a web of genes, the environment, biology, and psychologically all interacting. So from large-scale studies, we saw that nearly 700 genetic variants may influence vulnerability to depression, though each one adds only a small effect. Still, he let us know that when these genes meet life stress, the risk actually multiplies through what scientists call epigenetic changes. That is the environment acting on the genes to alter how the brain responds to future stress. So at this point, we thought that he was going to excuse us, but he went on to explore how early life adversity, trauma, and chronic stress can actually leave biological footprints, reshaping the hypothalamo-pituitary adrenal axis and stress hormone systems. And he showed us that overactivation of the HPA axis and stress hormone systems actually depletes serotonin and brain-derived neurotrophic factor, shrinking the hippocampus and affecting memory, motivation, and mood. He went on and unpacked the classic monoamine hypothesis. And here he showed us how deficits in serotonin, dopamine, and noradrenaline underlie most of the depressive symptoms that we know. And he also showed us why no single neurotransmitter actually can explain it all. So he expanded this a little to the what he called the glutamate GABA balance, where he noted that newer agents such as ketamine, which can be used in the context of depression, actually act rapidly by modulating these circuits. He took us a little deeper into the forest with neuroimaging studies which have revealed that depression is not something which is just at the cellular level, but it can be structural because neuroimaging studies have actually revealed visible brain changes such as thinner gray matter in the orbitofrontal cortex, okay, and anterior cingulate, altered connectivity in emotional networks, and even differences in how depressed brains tend to detect and respond to stimuli. So at this point, ladies and gentlemen, we thought he was done. He was almost getting done. He informed us that the story of depression does not actually end at the brain. So we examined the role of the immune system in depression, where inflammation, high C-reactive protein, interleukin-6, and other pro-inflammatory cytokines or immunomodulators and metabolic dysregulation form what the scientists now call the immunometabolic depression. When he was concluding, he quickly talked about the gut-brain axis, and here he let us know how gut bacteria communicate with the brain through the vagus nerve and inflammatory molecules, thus linking mental and physical health. So in brief, that was heavy, but it revealed that depression is not simply a chemical imbalance, but a whole body disorder. It is a story of genes meeting stress, the brain meeting the immune system, and the gut communicating with the mind. So tonight, we are going to close all this with the treatment principles of depression. That is, we are going to turn science into practice. Dr. Katama, I turn the microphone over to you. Please take us away. Thank you.
Thank you, Dr. Muyanga, for that recap of what we have looked at over the past 2 days. And today, we are going to go through the principles of treatment of depression. This is where we actually have to focus a lot because it plays a significant role in whether our patients will improve significantly or they will still be burdened by the symptoms of depression. Good evening, everyone. My name is Sadat Katama, and I'll be taking us through the final day of the module for depression. This we looked at on Tuesday, and we talked about the course of treatment of major depression, we looked at how an individual can be there without any depressive symptoms, but then they go ahead and develop depressive symptoms. And at a certain point, we then get these individuals and we start them on treatment. When we start them on treatment, that first phase is what we call the acute phase. And the goals of the acute phase basically are to ensure that symptoms are resolved. And this acute phase goes on until the symptoms have resolved, where we have what we call remission. After that, after achieving remission, then we go through the continuation phase. In the continuation phase, this should take about 6 months, whereby we are maintaining this state where the symptoms have remitted, preventing relapse or recurrence or reappearance of the symptoms. And for some patients, during this period of continuation, you might actually have to go for up to 9 months. For example, if someone has had very many previous episodes, long episodes of depression, if someone had psychotic symptoms within their presentation, you'll find that this continuation phase may take longer than just the 6 months. Then finally, after you've reached what we call recovery, you start on what we call the maintenance phase. And on this maintenance phase, the goal is to prevent recurrence. Basically here, we are going to focus on the healthy lifestyles, you focus on the personality vulnerabilities of the individual, and then of course the long-term self-management, while also considering the clinical strategies of the patient that you are faced with. So even if it is someone who is listening into this, basically, when they tell you that your treatment is going to take 1 year or more, you should understand that this is the science behind. We are targeting all of these things to ensure that the recurrence of the symptoms does not occur so much. Now, what are the actual basic principles of management of depression? These I'm going to mention just briefly, of which many of the things I'm going to say might not feature on this slide, but if you pay attention, you're going then to understand the theory behind the management of depression, all the way from the initial assessment until you reach the measurement of their treatment response. So the first thing basically is to conduct a thorough biopsychosocial assessment of the patient. This is going to form the basis of your diagnosis, your formulation, and your management plan. When you do a good history, you do a good examination, and you do a good investigation, you're then going to correctly diagnose the patient, which will then lead to the correct treatment plan. Then the next thing that needs to be done is obtaining collateral history where possible. Most of the time, patients are brought in by other people, and in this, we need to get information from those other people as well to see, because when you read the DSM, you're going to find that some symptoms actually, they will be that as reported by the person or those who stay with the person or those observant. So it is important that we get some history from those individuals. Then we go ahead and formulate a diagnosis as well as the differential diagnosis. So that is principle number 3. Formulation of a diagnosis and the differential diagnosis. When you get the right diagnosis, you're going to give the right treatment. When you get a wrong diagnosis, you're going to give a treatment for that wrong diagnosis, which will not actually help patient. And then the fourth principle is going to be establishing a therapeutic alliance with the patient. This is where you're going to talk to the patient, give feedback, and then you let them also understand their part of the illness so that they contribute the management plan that you're coming up with. And then another principle is supporting education and self-management. When we talk about encouraging these people to do things like behavioral activation, physical exercise, communication skills. This is what we are looking at, ensuring that these individuals can then have these skills which they might actually use in their day-to-day life, even when they are on treatment, because they are not under your watch every day, but they will go home, and when at home, there are things they need to do to ensure that their symptoms can actually remit. Things like adherence to treatment, and also coming in for reviews. So all these need to be done. Then it is important to engage the patient as a partner to determine the treatment goals. Do not set the goals as the therapist or as the clinician. The goals should be set in partnership with the patient, because these goals are aimed at improving the well-being of the patient. Then after that, you construct a comprehensive management plan. This should include things like safety, suicidal prevention, so that when you do this with the patient and or the support system or family, any relatives around, it is important because it is going to allow for you to see what changes are happening over time based on your plan. If your plan is not comprehensive enough, you're going to miss out on certain aspects which are going to lead to failure of remission of the symptoms. Then another principle is delivering evidence-based treatment. Do not just prescribe medications, or do not just choose a particular strategy. Go with evidence-based treatment, so that when you give it, you're basing on some science that has been shown that this treatment actually works for such patients. And then you go ahead and monitor. Finally, the final principle is monitoring the outcomes with what we talked about, the measurement-based care. Here, where you are rating the patient's symptoms using psychometric scales, where you're looking at the severity of the symptoms and over time how the severity is changing. At some point, you're going to see that probably the severity is not changing. Then you have to evaluate your management plan. Now, after going through all of that, after mentioning those 9 principles, the rest becomes easy, because you're going to actually base on this to manage the patient. When you diagnose your patient and then you formulate it, you're going to categorize the depression, whether it is mild, moderate, or severe. And for each category, it will have clear indications either for a particular course of management. For example, you find that in mild depression, the recommendation, sometimes you can just observe, sometimes you do just psychoeducation, educating the patient about what could be causing their depression and how they should manage themselves, the self-management that I talked about in reverting these symptoms. And then, of course, you might have to throw in psychosocial interventions. Some people, it is because they are having some issues within their lives, and then you have to deal with those. If at all it goes beyond, then you might have to do biological treatment, where you have to do patients. If at all these symptoms not go away with these conservative means. Then when you go to moderate depression, you have to go for the first line treatment recommendations, which we are going to talk about. These might be combined with either the first line can be just psychotherapy or antidepressant therapy, but in just a single medication, or even combining. And then for severe depression, here you must start with a medication, and then you add other therapies. And then, of course, there are those patients who will have resistant depression, and you might have to go for more novel agents, or even things like ECT, which might be recommended. Now, the guidelines for the management of depression based on that, on the severity scales, vary depending on where you are or which guidelines you choose to use. When you look at, we have the APA guidelines, we have the NICE guidelines, there are the CANMAT guidelines from Canada. So this slide basically gives you what should be done when. So for mild depression, you realize that all of them they are just recommending things like self-management, psychological treatments, that is for mild depression. However, when you go to the other side of severe depression, you're actually going to find the medications like SSRIs, SNRIs, ECT, depending on the response of the patient. So it is important that you put into consideration the guidelines you're using and you follow what those guidelines say. In the management of depression, I will start by talking about the psychological treatments. So there are several psychological treatments, and these have actually been shown to help the patients improve the outcomes as well as delaying the relapse of symptoms. So things like cognitive behavioral therapy, where people have distorted beliefs about themselves, about the world, about the future. This ensures that these negative cognitions are recognized, such negative thoughts are recognized, then response to them is made, and then you solve whatever problems there might be. Then you have things like interpersonal therapy, behavioral activation, mindfulness-based therapy. All of these have been shown to be effective in the management of depression. This is what I have just mentioned about. I've talked about these can be used as first line, especially for mild to moderate depression. However, for more severe forms of depression, they do better when combined with pharmacotherapy, with the medications. And research has shown that a combination of, for example, CBT and then the medications is superior to just the medication alone. So it is important that when you see a patient, if you're able to deliver the psychotherapy, the CBT, you go ahead and combine it with your management. In case you are unable to, then you should send such a patient to those individuals who can actually do provide CBT. Other psychological treatments, find like psychodynamic psychotherapy, cognitive behavioral analysis system of psychotherapy, problem-solving therapy. This one basically looks at the frameworks of things that are happening, like dealing with the stressors of the individual, so that they solve whatever problem there is, which might actually be perpetuating or precipitating the depression. And then, of course, motivational interviewing. This was initially designed for people using substances. However, it can be used even for individuals with depression, especially when you're trying to move them from ambivalence towards their readiness to change. Then we go to the pharmacological treatments. Now, for the pharmacological treatments, the primary pharmacological agents are the antidepressants, and these are in categories. They are different classes. Rather than just call them antidepressants, it is important to specify the kind of antidepressant you're dealing with, because then you'll be pointing at the mechanism of action that it probably works through. So you'll find things like serotonin, selective serotonin reuptake inhibitors, serotonin norepinephrine reuptake inhibitors, the monoamine oxidase inhibitors. So all of these agents have been shown to be effective, and they can be used as monotherapy initially while monitoring the response. In case the response is not adequate, then you might have to actually go for a combination of any of these antidepressants or other medications. Yesterday, we looked at this image, and we basically described where each of these medications do act. When you find the SSRI, the SNRI, the TCA, they all work on blocking this serotonin transporter, so that serotonin is not moved from the synaptic cleft back into the presynaptic node. While the monoamine oxidase inhibitor works by blocking this enzyme, amine oxidase, which is responsible for breaking down serotonin. So when you're giving your medication, you should know the kind of medication you're giving and where it acts, because sometimes it might not be necessary to combine certain medications. There are other mechanisms through which these antidepressants actually work. There are those that target the dopamine and adrenaline reuptake, and so they inhibit that reuptake. Then there are those that can have alpha-2 adrenergic receptor antagonistic effects, as well as the 5-HT2 receptor antagonism. Then, of course, there are those that block melatonin, dopamine, serotonin, and other receptors. Then, yesterday, we described how glutamate and the glutamatergic pathways might be involved in depression. And so there are novel mechanisms. Now, when you look at the role of glutamate and then agents that target the glutamate pathways, you find like a ketamine, which is an NMDA receptor antagonist, has been used and it has been shown to be effective, especially in individuals with treatment-resistant depression. So where you're having a patient is not responding to medications at all medications you're giving, you might have to go for such agents. Then we have, of course, I have talked about this. Based on the guidelines, the guidelines, the recommendation is that you start with monotherapy, one antidepressant at a time, except in situations where, for example, someone has serious psychotic symptoms, of which you might have to add another antipsychotic in that case. So you can choose from any of these SSRIs examples. You can find things like fluoxetine, citalopram. You find things like so when you are selecting, you need to know the medication which falls in that particular category. Because if you're going to go for adjunct treatment or where you have to combine medications, we should not give from the same class. So you find SSRIs, the TCAs, things like nortriptyline, amitriptyline, imipramine. Then you have the SNRIs, things like duloxetine, venlafaxine. These medications are actually available to us. Then, of course, so you're going to start with the first line, and these listed here are what fall under the first line according to the CANMAT guidelines, while the TCAs and the tetracyclic antidepressants, these are more newer agents, they are taken as second line. Then, of course, you may have to go to the third line, which is the monoamine oxidase inhibitors, as well as the norepinephrine reuptake inhibitors. Now, in case there is inadequate response, when do we say, what exactly are we talking about in terms of inadequate response? Basically, where we talk about non-response, if a patient's symptoms do not remit, they do not decrease by 25%, if the decrease in the number of symptoms of the patient from baseline is less than 25%, then you say this is non-response. Then it is partial response if at all the decrease in the number of symptoms is between 26 and 49%. This is why we talked about the measurement-based care. You need to be monitoring the severity of these symptoms so that you can know whether your treatment is working or not, whether your patient is responding to the treatment or not. So when you find that this patient is not responding adequately, what then do you do? First, you need to establish that you have the accurate diagnosis, and then that you are giving a sufficient dose of the medication, and then you establish adherence within the patient, as well as ruling out any other psychosocial factors that might actually be contributing to this depression. When you do this and you realize that your patient is having inadequate response, then there are strategies to deal with this. The first is increasing the dose or maximizing the dose of the medication you're giving. So that is in case you have not reached the maximum tolerable dose for that, or recommended dose for that particular antidepressant. The other possibility is switching to another antidepressant from a different class. For example, if you are giving a TCA, you might have to switch from a TCA to an SSRI. If you're giving an SSRI, you might have to switch from an SSRI to an SNRI, basically switching from one class to another class. However, there are possibilities of switching from one medication to another within the same class. That can also happen. Then the other possibility is combining two different antidepressants. You find, for example, you get something like an SSRI like escitalopram or fluoxetine, and you combine it with another antidepressant like mirtazapine. Then there's the other possibility of augmenting the antidepressant with another agent. You're giving this patient your antidepressant, but the symptoms are not going away. You can choose to add either lithium, or you add another mood stabilizer, you add an antipsychotic, and you find that this has been shown to be even more effective in case you're combining two different medications rather than combining just two antidepressants. Then we talked about combining antidepressants with psychotherapy. This can also be done, as well as other non-pharmacological but biological treatments like ECT, the transcranial magnetic stimulation, light therapy. All of these can actually be used to augment or to as adjunctive therapies where you combine with your antidepressant medication. So this is what you do when you're dealing with non-response or treatment failure. Basically, this just looks at the strategies for patients with inadequate response, and it just gives, based on the clinical evidence or the confidence with which someone actually be having when choosing their treatments. So you might have to switch to another antidepressant if you have substantial clinical confidence that the class you're giving or the antidepressant you're giving is the one that is not working adequately. Then these are the different considerations when switching. So you'll find that under the APA guidelines, psychotherapy is the first thing you consider adding to your antidepressant. While under the NICE guidelines, for them, they first consider antipsychotics. This is what they have substantial clinical confidence in using. Then the BAP, the British Association of Psychopharmacology guidelines, for them, they recommend any of these antipsychotics, the mood stabilizer, or psychotherapy, while the World Federation of Societies of Biological Psychiatry recommends antipsychotics and mood stabilizers. And the CANDIMAT, they recommend antipsychotics. So this one is just showing you, depending on which guidelines, what you would have to use or to consider first when combining with an antidepressant. So for the summary of these pharmacotherapy recommendations, you have to do first line. You start with 1, low dose and increase, and the first line is an SSRI or other newer agents. Usually, you evaluate the patient between 1 and 4 weeks and see if there is a need to add just either the dose or the treatment. And then you evaluate within 2 to 8 weeks for a need of change of treatment. Augmentation or adjunctive options, we have described them. You might use psychotherapy, mood stabilizers, and psychotics. And then, of course, continuation treatment should last for at least 4 to 24 months, depending on your patient and also the guidelines that you're using. Now, these medications, of course, they come with side effects, and this is just taking us through the different potential side effects that patients might actually might experience when they are taking a particular medication. When you look at the SSRIs, you'll find things like some nausea, vomiting, diarrhea, which are usual symptoms, side effects for almost all medications, fatigue, agitation, insomnia. The reason why we give them in the morning rather than in the night. Then for some, it can actually lead to sexual dysfunction, though it can happen, but not for every patient. Then, of course, headaches, weight gain, because tend to improve the appetite. For the SNRIs, since they lead to they also increase the norepinephrine, you're going to find some noradrenergic activity as side effects: increased pulse rate, dilated pupils, dry mouth, excessive sweating, and others. Then, of course, serotonin syndrome. This one occurs, though in rare cases, but it can occur, and this is an emergency that you actually have to deal with. Talking about serotonin syndrome might require another session. Then, of course, we have the TCAs and the MAO inhibitors. They all have the TCAs. You find things like sedation. The reason some people use amitriptyline for sleep, weight gain. Then, of course, these anticholinergic effects, dizziness. While the monoamine oxidase inhibitors, they can also give similar side effects. Then, of course, there are those other agents which also have side effects. Now, the dopamine serotonin receptor antagonists, with the moment you see dopamine, then you expect some extrapyramidal side effects that might happen in such patients. So it's important that you monitor your patients and you rule out such side effects. When to discontinue antidepressant treatment? Like I said, we have the 3 phases of management: the acute phase, the maintenance phase, the continuation phase, and the maintenance phase. So you should be able to determine that your patient has been adequately managed for you to discontinue the antidepressant. Here we have the wire guide to antidepressant discontinuation. You need to warn the patients, the caregivers, their families, their support systems about what can happen in case the patient suddenly stops the medication. Then you have to involve the support system in monitoring this patient in terms of adherence to treatment as well as resolution of symptoms. The recommendation is a slow tap of the antidepressant over a period of time. So you don't just stop the medication suddenly. Better to taper the medication off. And it's important to educate the importance of other preventive measures. The continuation of psychotherapy, the role of exercise, sleep hygiene, and safety concerns, especially for suicidal thoughts and plans, and homicidal plans. Of course, there are other ways in which depression is managed. We have the neurostimulation treatments. The first one, of course, is ECT. This one is basically electrical current is applied to the brain, triggering a seizure. So when the seizure is triggered, this is what is going to lead to the therapeutic effects. It's non-invasive, although it is done under light general anesthesia. Another approach that has been designed to mitigate the risk of the cognitive. So this ECT has certain side effects, including cognitive side effects. So some other treatments are coming up which can be applied to the brain through electrical current, but without the risk of cognitive side effects, like the magnetic seizure therapy. Others are the repetitive transcranial magnetic stimulation, similar to ECT, although for it does not require anesthesia. So you might find that this one might even be safer for the patient. Then there are others like transcranial direct current stimulation, which is thought to positively affect the neuroplasticity of the brain. Yesterday we talked about neuroplasticity and the formation of new connections between nerves within the brain, between the neurons. So there are other treatments like the surgical treatments. For example, the vagus nerve stimulation. Here, the vagus nerve stimulation basically is a direct intermittent electrical stimulation of the left vagus nerve in the neck via a pulse generator. So you are directly stimulating the left vagus nerve with electrical current. Then, of course, we have the deep brain stimulation as well. This is the neurosurgical procedure whereby they implant electrodes into the brain, which are connected to a pulse generator within the chest wall, and then can continuously stimulate specific brain areas. So all of these are biological treatments that have actually been many of them have been used, but many of them actually more research is just coming up on their safety, their effectiveness as far as management of the patient is concerned. Then when treating depression, there are things that we call unmet needs. Those things that might complicate the response to treatment in case they are not paid attention to. The first one is the inadequate response and treatment-resistant depression. If care is not given, you're going to find that the quality of life of an individual whose depressive symptoms have not been fully resolved, or they have not fully remitted, is actually impacted. So when you look at this graph, this is worker productivity and activity impairment outcomes. So you find that for individuals with treatment-resistant depression, the risk of absenteeism is way high. The total work impairment is higher than those without treatment-resistant depression. Overall activity, you find that those with treatment-resistant depression are a bit higher than the overall activity impairment is higher than those without treatment-resistant depression. When you look at this other graph right here, we are looking at the odds ratio of people either visiting a general practitioner, the ER, being hospitalized within a period of 6 months. So those with treatment-resistant depression, all throughout, they have higher odds of being in hospital or visiting the hospital than individuals with non-treatment-resistant depression. This calls for assessment, careful assessment, and management of the depression so that you resolve the symptoms. Then you look at functioning. Now, full functional recovery is a need that should be met, because if there is no full functional recovery, maybe because of some residual symptoms, the person's productivity is going to be low. We talked about this on Tuesday, and that is similar to what I have just talked about in the previous slide. Then, of course, there is cognition. This is to do with executive function, planning, reasoning, memory, attention, reaction time. So you find that when you look at this diagram here, one side you're looking at what favors people with depression, and then what favors the controls. So you find that individuals with depression, their cognitive function might have cognitive deficits even with resolution of the mood symptoms while on treatment. These cognitive deficits are going to affect them as far as their well-being and quality of life is concerned. So when you look at all of these domains of the cognitive functions, you find that everything is favoring individuals without depression, while those with depression, nothing is favoring them, be it attention, memory, executive function. So these usually are always present even with treatment. So that's why we need to adequately monitor these patients and assess all the different symptoms so that we can deal with some of these unmet needs. The other thing which is quite common is comorbidity, where you find anxiety and depression, or depression and other medical conditions. There might be the physical illnesses or other psychiatric conditions, addiction, substance use, anxiety, and others. So individuals with anxiety and depression, they tend to be more severely depressed, they tend to be more unemployed, they have a diminished quality of life, they have more suicidal ideation, They have a greater number of comorbidities, other conditions that come in, and they have a lower response and remission rate. When you look at this graph, here we are looking at the psychosocial functioning score, and the higher the score, the poorer the outcome we are having. So individuals with the anxious specifier of depression, we talked about the specifiers on Tuesday, and there is one called anxious with anxious distress. So individuals with anxious symptoms or anxious distress, their scores are generally higher on the psychosocial functioning score, whether work performance, marital relationships, family relationships, friendships, leisure, even the global rating of impairment. So this is important that we always assess our patients when they come in with depression. We assess them for anxiety and other comorbidities so we can manage them. On Tuesday, there was a question of the prognosis of childhood of depression in individuals with a history of childhood maltreatment. Now, you find that childhood maltreatment.
Dr. Katama?
Yes, please.
Yes, we should be concluding in a few minutes. Thank you.
Definitely. Yes, thank you. So when you look at childhood maltreatment, we have physical, sexual, or emotional trauma, and these are a critical factor in psychiatric diagnosis. Now, individuals who have suffered these ailments, they have more severe episodes of depression, and they have poorer treatment outcomes. So this one can tell you about what is likely to occur when you do provide treatment. So when you look at this study, when they used the HAMD and they looked at remission rates for individuals without abuse, up to 84.1% had remission of their depression with treatment with SSRIs or SNRIs at week 8. While those who had been abused between 4 to 7 years of age, only 15%, 15.9% had remission of their symptoms. The other and final unmet need is suicide, because depression is a risk factor for suicide, and individuals with depression have been found to be up to 20 times at risk of suicide. It is important to always assess our patients for suicide. The antidepressants can actually help with suicide, with these suicidal thoughts. However, certain antidepressants, especially the TCAs like amitriptyline, might even be used, for example, in overdose by patients in an attempt to commit suicide. So you should be careful when giving something like amitriptyline as an antidepressant for a patient who is highly suicidal. In summary, there is no particular universal guideline for the first-line treatment of depression, but evidence is there, and the guidelines are from different regions. Psychotherapy, antidepressant, monotherapy should be done first or in a combination, depending on the severity of the patient. It is important to monitor your patient for response. 2 to 8 weeks, and then you might consider switching to another antidepressant or augmenting the initial treatment with another. And then, of course, we have these other management modalities. But it is important that we pay attention to the unmet needs, quality of life, cognitive function, suicide, comorbidity, and others. Thank you for listening.
Wow, that has been quite an interesting session, Dr. Katama. Thank you so much. I know you have a lot to share, but still we have picked a lot. And we want to thank everyone who has tuned in into this interaction. We thank you, Dr. Ampamiz, all day from Gulu University, and other colleagues around. I have seen within the chat Dr. Lois Faith Nangiro. We are happy to see you around. And certainly our colleagues, students from Makerere, Gulu, Mbarara, KIU, Busitema, name it. We thank you so much for the time you have taken to join us. We hope it is not in vain. So shortly, as Dr. Katama is responding to the questions, I'm going to request Moses to put up the poll. We are kindly requesting you as the questions are responded to also be responding to the poll that is going to come on your screen. Please do not close it, because it will help us to improve the sessions that we are going to have next week and the following weeks. So Dr. Katama, I think it's time to dig right in. The first question was from Mr. Geoffrey Situma, who asked, what is the next course of action if the patient develops resistance to antidepressant therapy? I think actually during your presentation, you hinted about this, and it was actually after he posted this question. So since we have a lot, I think we can move to the next question. So Mr. B. Rakelen is asking that why could you switch? I'm reading verbatim. Why could you switch to a drug in the same class as the one that has failed to work, yet the mechanism of action is the same? Will there really be any change?
Yes, thank you, Lira, for that question. Now, when looking at these things, a patient might have a poor response to a particular drug, but when they can actually respond to another, even within the same class. Secondly, you may find that an individual was not taking the medication properly within the same class because of the potential side effects that the medication could actually be having, on towards that particular medication, but then when you change, it could be a different case. Then, of course, some medications within the same class, you may find that they might be safer than others. I'll give an example. When you are, for example, having a patient, you've been giving them fluoxetine or another SSRI, but then you find that maybe this lady has gotten pregnant. You might have to switch from that SSRI, from fluoxetine, to something which has been shown to be safer in pregnancy, like sertraline. So there are actually considerations that might be used when choosing to switch, even within the same class. Thank you.
Thank you so much, Dr. Katama. But one thing maybe we needed to note, that one, if you are talking about resistance, this was Mr. Situmwa talking about it. Resistance is a term that we can only use, one, if someone has failed to respond to two or more drugs which are in different classes. But the other element is, even if you've given this person those drugs, you need to be sure, one, that this person has actually been taking the medicine the way it should be taken. Two, that you had tapered the drug to the highest possible dose, or the most highest tolerable dose. Three, that these other recommendations we usually give in the context of treatment, which accompany the pharmacotherapy, such as psychotherapy, such as sleep hygiene, such as good nutrition, are all adhered to. So if this person has done that and this medicine is not working for a duration of 4 to 6 weeks, that is when now we can start having a conversation about the possibility of treatment resistance. But before that, we need to explore for all those factors. Then Mariam Kasozi is saying, thank you for the presentation. I'm curious to know about the switching, especially adherence assessment. Is it done as DOT? DOT, I hope, is directly observed therapy. Or if so, what period is it done until another assessment is made? Dr. Katama, over to
Yes,
you.
thank you, Mariam, for that question. So when we're looking at this, when we're doing the presentation, we saw when you might actually consider switching. So you'll, first of all, you have to establish.
Dr. Katama, sorry
Yes.
for just a minute. Colleagues, kindly note that the poll is already on our screens. We are humbly requesting you to fill it in as the questions are being answered, because at exactly 8, we have to end this interaction. So please, as they're answering, respond to the poll. In case you accidentally closed it, you can go to where, if you're on a laptop, you can go to where there are 3 dots on your far right. There is the word more. Tap it, okay? and then you'll be able to see what to do. Oh, there are polls and quizzes as well. Okay, Dr. Katama, please continue.
Yes, thank you, Dr. Mia. So, Mariam, so when we are looking at this, like we said, you have to establish the correct diagnosis. You are at the maximum dose for that particular medication that can be tolerated, and that there is adherence and someone is actually taking the treatment. That's why we talked about the involvement of support systems in especially monitoring the adherence. While you are assessing between 2 to 8 weeks, you assess and you realize that when you do your psychometric assessments, the patient's scores are still less than 50% in terms of response. Then you know that you are having probably failure of treatment and you might need to consider adjustment of the treatment. Thank you.
All right. Thank you, Dr. Katama. Then let me see. PX, what is this name? I'm a little lost. Furaha is saying, good evening. Can you tell us more about the treatment of severe forms of depression using ketamine? It is mentioned as an emerging and efficient treatment, but in our context, we know little about it. Is it available, cost effective, and safe? Thank you.
So ketamine, thank you, Fraha. So ketamine is actually available. This is a general anesthetic used quite a lot in surgical procedures, and you find it mostly in theater. So for people who don't go to theater that much, probably they don't have much idea about it. But yes, because it targets the glutamate system, it has been shown to promote synaptogenesis. Basically, there is restoration of neural connectivity. Now, ketamine can be used either as an IV medication or intranasal. It is available. The only challenge is that because it is a newer agent, the studies looking at its effectiveness are still just coming up. So for the use, it should be with caution. Of course, ketamine has particular side effects like hypertension, dissociation. There is that dissociation that it gives as a side effect, and also it has a potential for misuse. I think I've managed a patient with ketamine addiction. So you should be careful when choosing it, and you should use it in a context that is safe. Thank you.
All right. Thank you so much, Dr. Kata.
Yes,
Oh,
Dr.
thank
Mayang.
you. Thank you, Dr. Katama. So I think we need to dedicate the remaining 2 minutes to allow everyone to respond to the poll before we close this engagement. But as they're responding, I'm humbly requesting Dr. Mwesiga to give us a word in the remaining 1 or 2 minutes as we close. Thank you.
Okay, thank you, Mark and Sadat. I truly believe you have done a very great job over the last 3 days. Thank you for everyone who has attended. A reminder that we are going to be here for a few more weeks. Maybe Moses, you can pin up the schedule for the coming weeks. It will be the same thing. We'll progressively move from descriptions to treatment, and the idea is that to ensure that we are a bit better skilled in managing patients with mental illnesses. I'm really grateful. I've seen questions about the slides. Again, we reiterate that these slides are free. Just go to neurotorium.org, download as much as you want, but please don't plagiarize them. And these video recordings will soon upload them onto YouTube. I see it's 8 o'clock. Thank you very much.
Yeah, thank you so much, Dr. Mwesiga, and thank you everyone who has tuned in. For those who have already answered the poll, you're at liberty to drop off. Allow us to wish you a lovely night. We shall see you next week, same time, same link. We look forward to that. For those who have not completed the poll, kindly help us to complete the poll and you can drop off. Have a lovely night. Thank you.